Welcome to our video on ovarian neoplasm introduction and surface epithelial tumors. Let's get started. Here's our overview slide. As you can see, we'll be discussing ovarian neoplasms as well as surface epithelial tumors. So let's begin with ovarian neoplasms, starting with the definition. Ovarian neoplasms are neoplastic ovarian growths that, generally speaking, arise from one of these components of the ovary: the surface epithelium, which is the most common, germ cells, or sex cord-stroma. And it's important to note that most ovarian neoplasms are benign. Okay, moving on to risk factors. The primary risk factor for developing an ovarian neoplasm is long-term uninterrupted ovulation, for example, in the setting of old age, nulliparity, or infertility. This is because each time ovulation occurs, the ovarian epithelium gets disrupted, necessitating activation of cellular repair mechanisms. With each cellular repair event, cells have to divide, and the more often cells divide, the more likely they are to accrue mutations that can eventually lead to uncontrolled cell growth. Women who are older and women who have never been pregnant are therefore more likely to be on a long streak of uninterrupted ovulation, which unfortunately predisposes them to developing ovarian neoplasms. Other notable risk factors include obesity, including a BMI of greater than 30, endometriosis, hormone replacement therapy, genetic syndromes such as BRCA1 or BRCA2 mutations in Lynch syndrome, a family history of breast and/or ovarian cancer, and a personal history of breast cancer. As much as it is important to know the risk factors for ovarian neoplasms, it's also important to know the protective factors. As a general rule of thumb, anything that reduces the number of ovulation cycles over a woman's lifetime is considered a protective factor. Notable protective factors include the use of oral contraceptive pills for more than 5 years, multiparity, breastfeeding, tubal ligation, and hysterectomy. Although tubal ligation and hysterectomy have been definitively shown to reduce a woman's risk for developing ovarian cancer, the exact reasoning remains somewhat muddy. Some texts attribute this protective effect to impairment of ovarian blood supply and decreased migration of carcinogens to the ovaries from the lower genital tract. Other sources attribute it to decreased migration of cancer-prone epithelial cells to the ovaries from the fallopian tubes and the endometrium. Regardless of the exact reason, it's important to remember these protective factors as they're considered fair game for your tests. When it comes to clinical features of ovarian neoplasms, early disease is mostly asymptomatic, making it very difficult to catch these cancers early in their course. As the disease progresses, however, patients progressively develop nonspecific gastrointestinal symptoms such as bloating or early satiety, urinary symptoms such as dysuria and pelvic pressure, menstrual changes, and eventually ascites. Additionally, a pelvic mass may or may not be present on physical examination. Unfortunately, unlike lung cancer or colorectal cancer, there are no effective screening modalities for ovarian cancer. Most clinicians are forced to rely on history and physical examination findings to detect these cancers, and these remain largely normal up until the very late stages of disease. Once the clinical suspicion becomes high, pelvic ultrasound is typically used as the first-line imaging modality to assess the ovaries for masses or any other abnormalities. When it comes to the ultrasound of the ovaries, it's important to know the benign features and the malignant features of ovarian masses. A small cystic mass with no solid components or septations is more likely to be benign. A large mass with solid components or septations, on the other hand, is more likely to be malignant. More sophisticated diagnostic methods for ovarian cancer include advanced imaging, such as CT or MRI, tumor markers such as CA-125 or AFP, and direct surgical staging, for example, during an exploratory laparotomy. Importantly, if suspecting ovarian cancer, clinicians should avoid ovarian cyst aspiration or paracentesis of ascites. This is because malignant ovarian cells tend to spread via direct exfoliation. Hence, cyst aspiration or paracentesis may inadvertently lead to the spread of undiagnosed cancer. The general approach to the management of ovarian neoplasms is with surgical excision, followed by chemotherapy, radiation therapy, or both. For the purposes of exams, it's not high-yield to know any specifics beyond that. Now that we've established a general foundation, let's briefly discuss the different types of ovarian neoplasms. Here's an image that helps distinguish and categorize the various types of ovarian neoplasms. Notice that the ovarian neoplasms can be broken down into germ cell tumors, sex cord stromal tumors, metastases to the ovary, and surface epithelial tumors. For the remaining of this lecture, we'll be focusing on the surface epithelial tumors. Surface epithelial tumors are characterized by neoplastic growth of epithelial cells within ovaries or fallopian tubes. As a group, surface epithelial tumors are considered to be the most common type of ovarian neoplasms, with serous cystadenocarcinomas being the most common subtype overall. These types of ovarian tumors present mostly in older women. There are two notable findings on histopathological examination that are important to know for these tumors. Histology of serous epithelial tumors, which includes serous cystadenomas and serous cystadenocarcinomas, will reveal psammoma bodies. Histology of Brenner tumors, on the other hand, will reveal urothelium and the so-called coffee bean nuclei. Here's an image depicting the typical histology of serous epithelial tumors. As I just mentioned, the classic finding here is the presence of psammoma bodies, which are these circular structures that somewhat resemble an onion. Here's an image depicting the classic appearance of Brenner tumors. Note these nuclei with a central groove within them, which makes them look similar to coffee beans. Generally speaking, surgery is the mainstay of treatment for surface epithelial tumors, often with adjuvant chemotherapy. Clinicians can subsequently track the treatment response and monitor for cancer recurrence using the CA-125 tumor marker and CT scans. All right, now that we've covered the information, let's review with a question. A 78-year-old G4P4 woman comes to the physician due to bloating and abdominal enlargement, as well as a 15-kilogram weight loss over the last 2 months. Her last menstrual period was at the age of 60. She used to take oral contraceptive pills for 10 years before getting married. She breastfed all of her children. Her vital signs include a temperature of 36 degrees Celsius, a blood pressure of 130 over 80 millimeters of mercury, a heart rate of 82 beats per minute, and a respiratory rate of 16 breaths per minute. The physical exam reveals left lower quadrant tenderness. Pelvic ultrasound shows a large left ovarian mass with internal septations and solid components. Which of the following most likely predispose this patient to her current condition? A. Multiparity, B. Breastfeeding, C. Oral contraceptive use, or D. Age at menopause. All right, this multiparous woman presents with bloating, abdominal enlargement, and a 15-kilogram weight loss over the last 2 months. The pelvic ultrasound shows a large left ovarian mass with internal septations and solid components. This description is consistent with a surface epithelial ovarian tumor, most likely serous cystadenocarcinoma. Her last menstrual period was at the age of 60. This can be considered late menopause because women usually undergo menopause around the age of 50. Late menopause increases the amount of ovulation cycles, predisposing the ovarian epithelium to abnormal repair and malignancy. Therefore, option D, age at menopause, most likely predispose this patient to ovarian cancer. Recall from this slide that one of the risk factors for ovarian cancer is long-term uninterrupted ovulation. For example, patients who go through menopause at an older age. All right, let's discuss why the other options are incorrect. Option A, multiparity, is incorrect because this is a protective factor against ovarian cancer, because multiple pregnancies decreases the overall amount of ovulation cycles. Option B, breastfeeding, is another protective factor because increased prolactin during breastfeeding inhibits ovulation. Finally, option C, oral contraceptive use, is also a protective factor because it inhibits ovulation as well. So again, the correct answer is option D, age at menopause. And that concludes this lecture.